thank you very much for coming by.
Pleasure. Yeah.
I will try to present to you the new patellofemoral implant, the bipolar implant. What we have been doing for many years is to address lesions on the femur.
Yeah.
Focal lesions on the condyles or in the trochlea, using, for example, implants like this, or also implants sitting here. We also have a twin configuration with 2 pegs if they are elongated.
Okay.
We believe that it's in the convex side of the joint where the cartilage lesions, the early cartilage lesions, occur, whereas in the tibia, the concave side, the strain of the cartilage is not as great, but the strain of the bone makes them break instead in tibia plateau fractures. So the arc of the convex side makes it a very strong construct that squeezes a cartilage and thereby producing lesions. Right. I believe. So what we do is you start with an MRI here that allows us to reconstruct the knee in the computer. We see the lesion here. The pink is superficial damage, and the red is complete damage all the way down to bone. In the femur, in the patella. Then we suggest, as you can see here, a position of our implants. We also provide you with relevant slices, like 8 or 10 or so, of how this will sit in the different projections. You see the blue in the patella, the red in the femur. And then we send this damage marking report to you, and over the net, and you say, okay, this looks good.
So this planning will be done from where?
Yeah, so you send the MRI to us,
yeah.
And the MRI takes, it's some special sequences that we need, but you don't need to rebuild, no new software in the MRI.
Okay.
So we will help you to install the sequences in the MRI machine that you use.
Yeah, right.
And then we get that, we do the reconstruction, we send that back to you. You have a look at what we suggest. You say yes, fine, or you say no. And you say, I'd rather like the implant to sit a bit over on this side or that side.
Okay.
And then we change. And when you're satisfied, we say yes, okay. And then it takes another 4 weeks for us to manufacture it. And you will get the kit of the implant.
So all these will be patient specific?
Yes,
all
yes.
Right.
So, and together with the set, you get what we call a final design to show you how the guides, the epi-guide, will fit onto the bones in order to provide an excellent, perfect fit.
Perfect fit.
Yes.
Yeah.
And it is perfect. I've participated in hundreds of these surgeries, and it's amazing. But it's really, it's mathematics, you know. We reconstruct it in the computer. It's CAD/CAM. It's math, and so it will fit. So, for example, like this, you can feel yourself how well this
congruence.
It's a perfect congruence, and you see how you can slide it.
Yeah.
And what we do is we make this edge fit to that edge.
Okay.
So that's where it's supposed to go, and then you pin it down using K wires. We pin that down, pop, 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 and then it will sit very tightly.
Okay, and then we just...
And then you drill using this one to get a first shallow hole, rather like this, and then you twist it to get the double.
Okay.
To work your way down,
right.
And then we have this. We call it adjustment socket. That will, when you drill that down, same way, all the way to the bottom, and and then you can twist this. And by twisting this, you incrementally increase the drill depth by 200 microns.
All right.
And then you work your way down, and while you get down there, you check with the dummy, you take this out,
Okay.
you check
So this
with
is
the
the dummy
dummy.
trial. So all these things will come back in 4 weeks.
Yeah.
Okay.
You get all this, all that you need. And when you're happy, you
That's
tap
the
in
final
implant.
one.
Yes.
Okay.
In the patella, it is the same story, although the guide looks like this instead. And here you can feel how that fits.
Yeah, that fits well.
Yeah. And then you pin that down.
Okay.
And then you do the same thing.
Same things
with
again.
the
All right.
with the different, and of course in these, I mean, this is a chrome-cobalt patient-specific articulating surface.
Okay. So both are metal.
No.
So this is poly.
Yeah.
Okay.
So this is high molecular weight polyethylene, cross-linked and vitamin A doped. So it's the best possible. And you cement that down.
Okay.
But this you can put in without
Uncement. All right.
Yes.
So this has to be flush with the bone.
Yes. Yes. When we address focal injuries in the cartilage, we recesses below the surrounding cartilage.
All right.
But when there is
It's
a bony
already
surface,
bone.
you want it to be flush
With the bone.
even a bit proud.
Okay.
Depending on your preferences.
Okay.
But I would say you put it flush.
So are there options of this part being cemented as well? Because there might be some patients who are very osteoporotic.
Yeah, well, you can cement that if
So
you
we
want.
can cement that as
sure.
well.
Yeah,
All
sure.
right.
Sure. Yep. Our experience is, I don't think we ever have cemented one of these.
All right.
And agreed, depending on the age of the patient. But I mean, we are in the focal lesion, we are aiming for the gap age, between 35 and 65. Something
right.
like that. In the arthritic, you'd say that, okay, so OA may be older patients, but I think we have many cases of traumatic chondromalacia. They fall on there and they get a hole, or you have the dislocating patella, for example. And
so does this work well in that RDP cases always, recurrent dislocation of patella? Does it improve the kinematics of patella as well?
Well, I'll show you. What we are doing here is that we can, if you have a dysplastic patella or trochlea, we can actually change the sulcus angle with our implants. Again, in discussion with you over the net, but so we can make this any shape, and so that would be.
So could we offer this to patients who have recurrent dislocation of patella, who have failed their MPFL reconstructions?
Yes, and if they have developed OA, it's really up to you if you want to do this before they get OA. But it's really up to the responsible surgeon.
Time will tell that if that is an ideal indication for that.
Yeah. But it's a problem in my country. We have a lot of these young women, with squinting patella. They flip up. And we operate them with advancement with PDFJ ligaments with tuberosity transfers. And they come back to us 15 years later with osteoarthrosis. And then they are 35 years old. And they would be perfect cases for this, I believe. So, so there you are. We are, unfortunately, I cannot give you any follow-up data because we just launched this. We have done just a few cases actually. So, but there are many equivalent products on the market with a bipolar replacement. and they work fine. I personally would suggest that with the precise instrumentation that we provide you with and with the patient-specific implants, we should have
better results.
Even better results. But that remains to be proven. I agree.
so in the coming time, could that time period of 4 weeks, could that come down?
Yes, we are working
because
on
we get patients who have who don't plan so early. Because if somebody wants a surgery, they want it within a week or so. They are not ready to wait for so long. They either change their mind, they go to some other surgeon, they'll offer a complete
Yes,
knee.
I've heard this. I mean, this seems to be, they tell me that here in India, many patients, they want a second opinion, a third opinion, a fourth opinion, and then they go to a doctor that doesn't know about
Doesn't
this.
know about this,
No, never heard of that.
Never heard of that.
Go for that. Go for a total knee instead.
Yeah.
So we're working on it. I mean, we are discussing maybe we could set up shop in India.
Yeah.
You know, because you have excellent IT facilities, competence,
and number of patients number of patients are high too.
And so that may come, but not during the next year, possibly. It will come eventually, hopefully. So there you are.
Yeah.
What do you think?
Looks like a good option. I had a patient around 3 days back who was around 40, and she had perfect knees, but the PFJ was very bad. A lot of osteophytes, and I had nothing much to offer other than maybe a hyaluronic acid injection, or I think she would fit into this category.
That's what I hear, that this is a common problem in India.
So if we have to revise it to a total knee maybe another 10 years later, so that's not an issue.
No. And what we have done actually is we have used a number of standard total knee sets, instrumentations, and we've done all the cuts, and we see that in most cases we excise the entire footprint.
All right, so no defect is left.
No, yes, and in some instances, depending on how it sits, you have a contained lesion that you can fix with bone chips or cement.
Right.
So it's easily revisable. We do have revisions, of course. We have revised. We've put in we are approaching 2,000 of these, and we have about 35 revisions. So our revision rate is very, very low.
What are the main reasons for revision? After time, or?
Most of our revisions come early. It's strange, and to me that indicates that that indicates the cases that we should not have operated for wrong indications, sometimes faulty technique.
Learning.
We have a couple of infections that we don't have a single case of loosening. Not one single case.
It shouldn't be, because it is not a joint where there should be much stress once it is inside the bone. So loosening should not happen.
Yes, it's
and it's good cancellous bone, and it should take up pretty.
Yes, and the hydroxyapatite makes it sit, and then you have the cement in the patella, but it's recessed again. So it should be.
So this is the original implant?
I don't think that is this is not the kind of polyethylene we're using. So this is
just a demo.
Some kind of
fake plastic.
Fake plastic.
All right.
Yeah.
So looks promising.
Good. Happy to.
We need to come over to you to get the tricks.
Well, or I come to you.
Yeah, most welcome for that.
Yes.